Good afternoon, everyone. Thank you so much, Dr. Nafula, for the brief, for the introduction. Allow me to share my screen.
Yes, Doc, please.
Great. Can you guys see my screen?
Yes, we can see your screen.
Okay, thank you. So as Dr. Nafula said about cancer pain management, it's one of the pretty broad topics, and there is it's a huge burden. A lot of childhood children come in with cancer, and they do come in with a lot of pain burden symptoms, and there's also very little literature. There's limited literature on that as well in terms of management. So it's and it's a very broad topic, but we'll try and talk about it a little bit today. And the objectives for this talk today, we want to see about what is the current burden in Kenya. We'll talk about assessment of pain. We look at a few tools that we can use to assess the severity of pain. And then we'll talk a little bit on the management options that we have, the guidelines from the WHO, and we'll spend a little bit of time talking more about opioids, which is commonly used to manage this sort of pain. To begin with, this is something that got my interest. It's from a document called Needless Pain, Government Failure to Provide Palliative Care for Children in Kenya, where they're saying that Kenya has a high and increasing rates of childhood disease and child mortality. Hundreds of thousands of children suffer from AIDS, cancer, sickle cell disease, and other chronic, often fatal or otherwise life-limiting illness, and they often experience severe debilitating pain. So this is true, and it's pretty much similar. There's a lot of literature from other countries as well, which is also showing that pain is usually undertreated in children. So together with this, I came across this study, which was assessing the prevalence of pain and adequacy of analgesic prescription among children admitted at Trans Nzoia County Referral Hospital in Kenya. This is a 2021 paper, which was there, where they were assessing pain in children and the adequacy of analgesic prescription. And what they found is that 4 out of 5 children had pain. So this shows that the high prevalence of pain that is there. And they also found out that the analgesic prescription were inadequate. So there was low adequacy of analgesic prescription. And they reported on some of the barriers, which include drug availability, staffing, and knowledge, which is also known to so many of us here as well. That drug availability is one of the limitations that we have, and staffing is another very common limitation that is always reported and always comes out. This was another study which was done in 2014. It's a bit old, which was done at Kenyatta National Hospital General Pediatric Wards, where they found a prevalence of 78%, which is also very high. And they saw that mostly mild to moderate pain was identified in younger children and moderate pain among older children. And only half of the patients received adequate analgesia as well. So despite advances in oncology, undertreatment of pain is still a major problem. Pain remains a central burden associated with all cancer diagnoses. So it's reported everywhere globally about the burden of cancer pain in children. So by definition, using the ISP definition of pain, like what is pain? ISP is the International Association of the Study of Pain, which defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So it also reminds us that pain is always subjective. So it's what the patient reports, and we have to believe them in terms of what they tell us about when they describe their pain, and we have to believe, because it's very much subjective. No two people will feel the same pain at the same level despite having the same diseases. So it's pretty much very variable depending on the environment, the circumstances, and everything. As it's also said that pain is a multidimensional phenomenon which involves sensory, physiological, cognitive, affective, behavioral, and spiritual. components. So this talks about the multidimensional phenomenon where all these components can alter the way the pain is experienced by modifying the transmission of unpleasant stimuli to the brain. Inadequately managed pain in children can lead to chronic pain, anxiety, depression in adulthood. It has also shown that it can also lead to post-traumatic stress in both the parents and the child as well. Classification of pain. Pain can be classified according to this duration, underlying mechanism, situation, etiology, which is cancer, non-cancerous, anatomic location of which part of the body is involved. As for duration, pain can be classified into acute and chronic pain. Acute pain is usually due to an acute injury or illness, has a definite onset, limited duration and predictable. As the wound, the injury or the illness is healing, we know that the pain is subsiding and the patient is recovering. So it has a very definite onset, which is also accompanied by anxiety and clinical signs of sympathetic overactivity, where you can have, like, maybe a patient comes in with tachycardia or maybe increased blood pressure, increased respiratory rate. So that's in acute pain. And the treatment is mostly focused on trying to treat the cause, and you can use together with the short-term use of analgesics. Now, chronic pain is something, the onset is pretty gradual or ill-defined, persists longer than expected healing time. This is pain that can persist even when the injury or the illness is healed, but the pain is still persisting. So it goes beyond the expected healing time. There is some literature where they have put a time frame of definition saying that pain that persists more than 3 months. But there's a lot of literature say that it's pain that persists longer than the expected healing time. This usually leads to the patient appearing depressed, develops anxiety, or feels withdrawn, and treatment is directed at underlying the disease where possible, use of regular analgesics, and a holistic care where trying to focus on the multidimensional phenomenon as well. The underlying mechanisms. So usually different types of pain respond differently to analgesia, and that's why it's very important to identify and determine the type of pain. So for the underlying mechanism, patient with life-limiting illnesses can have both neuropathic and nociceptive pain, and may also have more than one cause of the pain. So they can have like a mixed type where they have both. They can have various different causes of pain. Nociceptive pain is produced when by the stimulation of sensory receptors in the viscera or the somatic structures. In that case, the nerves are intact. So you can have nociceptive, which is superficial somatic and deep somatic. Superficial somatic usually arises from the receptors, nociceptors, skin, mucosa, mouth, nose. It's a well localized pain. The character is usually sharp and may have a burning or pricking quality. And it could be post-surgical, superficial trauma, superficial burn, abscesses. And there's the deep somatic pain, which occurs from the bone, joint, muscles, connective tissue. Its localization, it shows that it's a well localized pain with tenderness and palpation. Usually it's dull. The character of the pain is usually dull, aching, throbbing. This can occur in examples of bone metastases, fractures, muscle cramps. Even in sickle cell vaso-occlusive episodes, you can see this kind of pain. There is then nociceptive pain, which is visceral type. This usually arises from the internal organs, the nociceptors from the internal organs like liver, pancreas, pleura, and peritoneum. Localization, it's poorly localized. Usually patients come in like with sort of like a radiating kind of pain. So it's pretty much diffused, but palpation over the site may elicit an accompanying somatic pain. Usually, the character of this pain is usually vague, dull, it's aching, cramping, or tightness. It feels like there's deep pressure. It could be colicky. And then there's the neuropathic pain where it's produced where there's damage in the central or peripheral nervous system. In this case, the nerves are actually have a problem. They are abnormal nerves, and it's generated at various sites and is always stimulus dependent. The localization, it's again poorly localized diffuse pain in the area of sensory dysfunction. The character, it's difficult to describe, but you can describe it as like it's a burning, pricking, pins and needles, sharp or shooting type of pain. This can occur from spinal cord injury, from trauma, from tumor causing the spinal cord compression. You can have like neuropathies, peripheral neuropathies from HIV, from cancer, anti-cancer treatment, diabetes, and the phantom limb pain. There's also a third category where it was introduced by the International Association of the Study in Pain in 2017. They call it the nociplastic pain, which they're saying it's by mechanistically different from the nociceptive and neuropathic pain. And this is the pain that occurs where there's no evidence or of tissue damage or a nerve damage. The mechanism is not well understood, but they're linking it to central sensitization, and they've given also criteria to clinically classify nociplastic pain. This is a report of pain of at least 3 months duration, report of regional rather than discrete distribution, pain that cannot be explained by nociceptive or neuropathic mechanisms, show clinical signs of hypersensitivity. So this is one of those types of pain where the colleague, which is a chronic type of pain, and it's one of they call it also the primary pain disorders, which we can actually see them in children, and it's kind of pain that where children like present with chronic headaches or chronic abdominal pain or chronic musculoskeletal pain. But the kind of pain does not fit into the nociceptive or neuropathic pain category. So this is something which was introduced very recently in 2017. According to situation, you can have breakthrough pain. This is a transitory exacerbation of the pain that occurs on a background of otherwise well-controlled pain. There is well-controlled baseline pain, and there is the incident pain, which occurs only in certain circumstances. It could be from the movement patient, and there's a procedural pain related to the procedures or interventions. So these are some of the classifications of pain that are on the well-written, and something that very important for us to assess to help us understand the type of pain, and in order to be able to manage that pain. So causes of pain in cancer. Cancer is the multiple reasons of why patients can present with pain in cancer, and a lot of times the pain that children present with in cancer is because of the diagnostic investigations that are done, the therapeutic procedures, treatment, and you can also have the tumor-related pain, which is from when the tumor is directly invading into the neighboring organs, pressure from the tumor, distension, obstruction, nerve tissue compression, and inflammation. Pain severity assessment. So goal of pain assessment is to identify pain, assess severity, and also to assess the response to interventions that are there. Usually, parents and children can be asked to rate the pain severity of pain episodes using general categories: mild, moderate, severe, and how pain can impact the daily function There are various pain assessment tools exist and can be used to supplement this. In children, usually you can have the self-reporting tools. So depending on the age, there are various tools that can be used. There's the self-reporting tool, and there's the behavioral observational scales that can also be used. Now, remember that children may not report pain or underreport pain because of the fears of the intervention. Maybe they fear the doctor, maybe they fear the treatment that comes with it, or injections. So there's a tendency of children to underreport pain. Therefore, it's very important to supplement the assessment by asking the parents, the caregivers, by observing the behaviors of the child as well, can also help in assessing the pain. It's very important to also remember about the parental response to child's pain can impact the child behavior as well. So a self-reporting tool, this relies on the cognitive ability. It's for older children who can understand, and it's used. You can use the age-based pain rating scales. There are various validated tools that have been used. For example, in the age of 3 to 8 years of age, commonly used tool is the Wong-Bakker Faces Pain Rating Scale. And for 8 to 11 years of age, you can use the visual analog tools. In adolescents, these are children who well understand, so you can use the numerical rating scales, and you can also ask for further description, which can help you to understand the pain more. And this includes the location, radiation of pain, intensity, duration, constancy, frequency, relieving and aggravating factors. Observation tools are usually used for infants and children, or for infants and in children who are unable to self-report, children with neurological problems who are not able to self-report. So you can use the observational tools. These are various parameters, observational parameters that are utilized, and based on that, you score the parameters and get a total score. So the FLACC is one that has been shown to have the highest clinical utility. I think no tool is recommended over another. This may underestimate compared to the self-reporting tool. So other sources of distress, which is hunger, anxiety, phobias, must also be considered when you're using these tools. Parental response to child's pain can impact the child's behavior. So these are some of the assessment tools that are there, which are in the literature, which are being used and which we can use as well. There is the CRIES, which is for the neonates. This are the parameters that they look at are the need of oxygen, increased vital signs, expression, and sleepiness. It's from 0 to 10. The pain score is from 0 to 10, and each parameter has a point from 0 to 2. And then there is the NIPS, which can be again used in less than 1 year. This is the neonatal infant pain scale. Again, there are various parameters that they look at, and there's the FLAS, which is the face, legs, activity, cry, consolability. This is FLAS is the one that I've seen commonly, which is also used here in Kenya. And there's so many other tools, that the CHOPS, Oucher, which can be used. And these are more where you can have besides the observational, you can have the numeric rating skills for older children, visual analog for even older children, and the pain diaries for much older children can be also used. This is the RIPS tool, the Relay Infant Pain Scale Assessment tool, usually which can be used for children from 0 to 3 years. And the behavior, the parameters they're looking at is the facial, body movement, sleep, verbal, consolability, response to movement and touch, and each parameter has a score from 0 to 3. So from the observation, after observing, you can actually score and get a total score based on this on the observation that you have observed and based on these parameters. This is the FLAS, the face, legs, activity, cry, consolability, which again has 5 parameters, and each parameter has a minimum score of 0 to maximum score of 2. So the result in total pain score should be between 0 and 10. This is how the Wong-Becker faces pain rating scale looks like, and below is what a numeric rating scale looks like, where you can have numbers from 0 to 10, where 0 is no pain and 10 is the worst pain. Where in the faces can have faces of 0 to 10, and as the pain increases, the intensity of the pain increases, there's a frowning with the tears towards the end. These are other tools which are also readily available and can be used. The one on the left is just where you can ask the child to point on the intensity, where up is very, very much in pain and down no pain at all. And this is for the number again. So it's also important to identify the location of the pain, and in children it becomes very difficult. So you can use various graphic outline of the body and ask the patient to color, so they can help to tell you where the pain is. Mostly, is it in the upper arm, lower limb? Older children can actually reliably locate pain, and they can tell you. So there are other various graphic-based pain location tools, adolescent and pediatric pain tools, pediatric pain questionnaire that can also be used, can assist in further classifying the type of pain and the location where it is. This is the example of graphic-based pain location, which can be used. You can just show it to the child, and they can actually point out and will help you to say where the pain is, or down there with the procedures that are causing pain. They can help to identify. This is another tool that can be used to describe the type of pain that is there, how frequent the pain is, how does it impact the activities. And this is the body chart, where the child can color to show where, to mark where the pain is. And on the right side is to show, point to or circle as many of these words to describe the pain. So these are different words that can be used, which the child can use or show to describe the pain. So these are various tools that can be used to document the type of pain, the severity of pain in children. This is an algorithm to help in the assessment and measurement of pain, where it's very important to classify and evaluate the pain, because it will inform you on your interventions for the management. So the pain assessment can be used. You can do it from the tools that we have seen, using the medical history, where you can ask about the previous pain experiences, previous analgesic treatment, current pain experiences that are there, physical examination of these patients, and then pain measurement approach, select age and development appropriate tool. Try and use this tool more frequently. So it's advisable to use the same tool when you begin with the tool. When you're doing a reassessment, it's advisable to use the same tool at intervals to help assess and check if, to evaluate the intervention. Following the assessment, you develop the individual plan, which includes pharmacological and non-pharmacological interventions, and then you implement the plan. And then the cycle begins where you go for the reassessment and check on the impact of your interventions. And if there's no improvement in pain, you come back, adjust the plan, and implement the plan and reassess again. So during management of pain, there are some important considerations which have to be considered. The type and duration of pain is very important to classify, because patients respond differently. Different types of pain respond differently to analgesics. Therefore, to identify the type and pain, it's very important. Asking about the current pain medication, because that will inform you on how the patient is responding to the current pain medication, and then is there a need to adjust or change the medicine. Prior experiences with pain medication, that is, were there any side effects before or any toxicity that was there, which will inform you on how to plan with the treatment. Previous use of non-pharmacological interventions, which interventions were tried, which interventions worked, which didn't work, what can be changed, the child coping skills, and always important to consider the multidimensional phenomenon, the components of social, cultural, and spiritual factors that can influence the pain. Largely, you can call it the concept of total pain. This is the pediatric multimodal analgesia, where considering the multidimensional phenomenon in the management of pain, you are targeting the various components which can cause pain. They work synergistically, and not only the pharmacological treatment, but plus the non-pharmacological interventions that can be used, like rehabilitation, psychology, cognitive behavioral therapy, skill-based training, integrative therapies, where you can have acupressure, acupuncture, aromatherapy, regional anesthesia, trying to bring out a normal life in the children, where you ask them to attend school, sleep hygiene, social, involve them in sports, spirituality, and then of course the use of pharmacological medications, basic analgesics, and opioids. General principles of management. Regular assessments is important, because it will help you to assess your interventions. Always remember including non-pharmacological measures. Usually the non-pharmacological measures are always forgotten, and which is one of the reasons why we have inadequate management of pain. We have a tendency of just focusing on the pharmacological prescriptions, and we forget the non-pharmacological, which also plays a very important role in management of pain, considering the multidimensional phenomenon of pain. Usually oral analgesics are preferred. It's a safer option to give. IV, depending on the individual indication, intravenous, subcutaneous can also be used, and rectal can also be used, but the bioavailability through the rectal is unknown, therefore it's not recommended. Intramuscular is also not recommended, because it can elicit more pain. Considering anticipating the side effects of analgesia. So when doing the regular assessment, it's also important to assess for any side effects of the analgesia, and knowing that what side effects are possibly there, anticipating them, trying to prevent the side effects that could occur, and managing them when they occur, and remembering the adjuvants, which can also help in management of pain. The non-pharmacological measures, they are physical measures, which include massage, heat, cold stimulation, acupuncture. They are the behavioral measures, like exercise, relaxation, art, and play therapy, and cognitive measures like distraction, hypnosis, psychotherapy. This help trying to distract the child from the focus, and there are very much useful in reducing stress and anxiety during invasive procedures. Before taking the child for any invasive procedures, you begin talking to them, informing them about the procedures, how it's, give them examples how it's going to be, and then trying to distract them during the procedures. It helps in management of pain. So this is something which is very much neglected, and involvement of the parents in these non-pharmacological measures has also shown to play an important role and improve the outcome of pain management. Pharmacological measures, the key concept is using a two-step strategy, trying to dose the medicines at regular intervals, avoiding the PRN or as needed schedule, using the appropriate route of administration. Preferred is by mouth, and adapting the treatment of the individual child by the individual. So this is also the recommendation from the WHO. The two-step strategy is the using of the two-step ladder in children, where there's step 1 and step 2. Step 1 is for the mild pain, where you use non-opioids plus or minus the adjuvants, and if the pain persists or increases, then you move to step 2, where you use the strong opioids. This is usually for moderate or severe pain. You can combine the strong opioids with the non-opioids plus or minus adjuvants. Always remember, when you're prescribing the opioids, consider prophylactic laxatives to avoid constipation. In step 1, for mild pain, generally it is can be adequately treated with non-opioid analgesics like acetaminophen and NSAIDs. You can use NSAID alone or acetaminophen alone or in combination. And most commonly used ibuprofen is NSAID. The most commonly used NSAID is ibuprofen in children, and they're very useful. NSAIDs are very useful as an adjuvant for bone pain. Remember, they have a maximum dose that can be 24, which can be given to children. So they have potential toxicity, and acetaminophen is one of the causes of hepatotoxicity, and NSAIDs can lead to gastrointestinal and renal toxicity. There's also a tendency from the NSAIDs to cause bleeding as well. Caution is on the antipyretic effect, especially when children, when they're on chemotherapy, they can have neutropenic fevers, and this prescribing acetaminophen and NSAIDs can mask the fevers, which can then bring out a late diagnosis of the neutropenic fevers or infections that can occur from the chemotherapy drugs that they're using. And children tend to have blood cancers. Then again, this can put them at the risk of bleeding from the antiplatelet effect of NSAIDs. So when we are prescribing this, always remember this, that it can mask the fevers and can put children at a higher risk of bleeding. The dosing of step 1 analgesics. So acetaminophen, the recommended starting dose is 10 to 15 milligrams per kilogram every 4 to 6 hours. The maximum is 1,000 milligrams. Ibuprofen is 4 to 10 milligrams per kilogram every 6 to 8 hours. And then patients who have GI issues or kidney issues, you can consider using the celecoxib at the dose of 10 to 25 and ketorolac as well. For moderate and severe pain, morphine is preferred and most commonly used. Currently, we have morphine available in oral, sublingual, subcutaneous, IV, rectal preparations. You can consider alternatives when you develop intolerable side effects or when intolerable side effects are experienced. So alternatives can be used. Opioids usually don't have a ceiling dose or a maximum dose. The appropriate dose is the dose which relieves pain with tolerable side effects to the patient. It can be used in combination with non-opioids, which is the acetaminophen and NSAIDs, and can also be used in combination with adjuvants. And always remember prescribing a laxative together when you're prescribing opioids because of the constipation as an adverse effect. There are other types of opioids. I'm not sure about their availability outside Nairobi, but it's hydromorphone, oxycodone, hydrocodone, and fentanyl. So hydromorphone has similar properties to morphine. It's more lipid soluble. Therefore, they say that it may increase the potency and may slightly have a more rapid onset compared to morphine. Oxycodone has similar properties to morphine, but it's more potent with a longer half-life, and hydrocodone has a similar potency as morphine. Fentanyl, the available preparations is IV, and you can have the transdermal form, which has prolonged analgesia. So ideally, as initial dosing, avoiding transdermal form you should avoid transdermal form because not sure of the optimal dosage, and it takes a time while there's effect, and it has a prolonged analgesia. So IV preparation has shorter onset and duration of action, which can be used. The starting doses of opioid neonates for morphine for intravenous subcutaneous injection is you start at a very low dose, which is 25 to 50 micrograms per kilogram every 6 hours. And for fentanyl, IV injection is 1 to 2 micrograms per kilogram every 2 to 4 hours. But the recommendation is to work together with a pain specialist or the pediatrician when you're or anesthetist when you're planning to give IV opioids. It's better to involve them and work with them before you begin the IV opioids. For oral, for opioid naive infants, that is from 1 month to 1 year, can begin at 80 to 200 micrograms per kilogram every 4 hours. And again, the same for IV injections. It's preferably to work with closely with pediatricians, pain specialists, or anesthetists. But your preferred route of administration is oral. Same with fentanyl and oxycodone. These are the doses that can be used for IV and for oral oxycodone. For children 1 to 12 years, the dose is a bit higher for oral morphine, which comes to 200 to 400 micrograms per kilogram every 4 hours. And for 2 to 12 years, it's 200 to 500 micrograms per kilogram every 4 hours, so maximum of 5 milligrams. Now, the available oral morphine, immediate release morphine that we have, 1 mil is 10 milligrams. Therefore, it's becomes difficult to titrate the dose. The one that we have available here in Eldoret is like 1 mil is 10 milligram. So it becomes very difficult to titrate the dose. But what I would recommend here is to work closely with the pharmacists to be able to calculate the dose and get the right amount of morphine that we can give to children. More on the dosage for other opioids, the fentanyl, hydromorphone, methadone, and oxycodone. So for the initial dosing, the objective is to try and obtain pain relief and avoiding unacceptable side effects or just having tolerable side effects to the patient. So the doses will vary depending on the severity of the pain, type of pain, and pre-existing opioid tolerance. Patients who have used opioids before, the dosage you might start might be a bit higher compared to those who are opioid naive. And depending on the type and severity and the response of the patient, so your dose will depend on that. Usually it's preferred to use short-acting agents and try and schedule the dose every 4 hours, which can help you to titrate to get the optimal effect and have frequent assessments to monitor the the response to treatment, and also the adverse effects that can come. Based on the response, you can increase the dose by 25 to 50% of the initial dose until adequate analgesia or intolerable side effects appear. If pain is severe, increase the daily dose by 50 to 100% only in severe cases. But if it's mild to moderate pain, you can just increase the dose by 25 to 50%. Escalating pain, you can have patients who have, despite the treatment, they can have this pain which is escalating or increasing. So consider breakthrough pain, and you can consider prescribing, administering them the breakthrough doses. If not, you can recalculate the opioid dose or increase the opioid bolus by 30 to 50%, which is every third dose if pain continues. So for every third dose, you can increase by 30 to 50% if the patient still has persistent or increasing pain despite from your assessment. Once adequate pain control is achieved, you include the increase opioid boluses that you gave and recalculate a new 24-hour dose. Usually at this time, also consider adding adjuvants or non-opioids for these patients if they are not on any. And reassessment, trying to identify the type of pain, can also be important because it will help you to draw the plan for pain management for these patients. If significant adverse effects are experienced, consider changing to a new opioid. That's called opiate switching or opioid rotation, where you use the table of ecoanalgesic dose, and once you calculate the new dose, you reduce by 25 to 50% to avoid the cross tolerance. And from there, gradually, then you can titrate upwards again of the new opioid and the new dosage. Weaning off. To avoid withdrawal symptoms of these patients, you do a gradual weaning. Abrupt weaning may bring withdrawal symptoms to the patients. So following short-term therapy of 7 to 14 days, reduce original dose by 10 to 20% every 8 hours gradually, increasing the time interval. And if patients have been on long-term therapy, so you do a more gradual reduction of the dose, which is by 10 to 20% per week. Some of the common side effects that can appear are sedation, respiratory depression, nausea, and vomiting. So sedation is something that which can happen in patients, and prevention is to avoid using or de-prescribing other sedating drugs that are there, and just educating of the patients or the parents that this may occur for a few days and resolve spontaneously. If there's persistent sedation, consider reducing the dose of your opioids or opioid rotation. And you can also consider psychostimulants can also be used. For respiratory depression, monitor the sedation and respiratory status of this patient. When you titrate your opioid with care, you can actually avoid respiratory depression when you titrate your opioid with care. But usually with overdosage, it's some of the side effects that can appear. Therefore, when you notice that, consider reducing the dose or rotation if there's excessive sedation. And when you have respiratory depression, there's management involves supporting the respiratory system and administration of the antidote, which is naloxone. Nausea and vomiting, again, is one of the side effects that can commonly can be seen. So recommendation is to slowly and steady titrate of the opioids, and you can use a short-term period of antiemetics like ondansetron. For management, when you have trying to identify other possible causes of nausea and vomiting, like maybe GI irritation, peptic ulcer disease, gastritis, or intestinal obstruction, which can also cause nausea and vomiting. Consider reducing the opioid by 25%, or consider opioid rotation if nausea and vomiting is refractory. Opioid-induced neurotoxicity, try and avoid, eliminate non-essential CNS activating or depressing drugs. For management, identify other possible reversible causes which could lead to neurotoxicity. It could be metabolic disorders, hyponatremias. Consider opioid rotation, hydration, opioid dose reduction, and discontinue other offending drugs like benzodiazepines. Constipation prevention is laxative, and management is assessing the cause of constipation, and can't identify and you think constipation is because of the opioids, consider giving enema or manual disinfection can help. Agents that are not recommended in children are codeine and tramadol. The US FDA in 2017 issued warnings and contraindications for use in children of codeine and tramadol for children below 12 years. This came from when they noticed death from the use of codeine and tramadol amongst children. So therefore, safety and efficacy problems are related to the genetic variability that affects metabolism, leading to ultra-rapid metabolism. Younger children in infants usually are not able to metabolize, but older children are able to metabolize codeine much faster than even in adults. Therefore, the potency and the bioavailability is not clear. So they're called ultra-rapid metabolizers, which can lead to now toxicity of the opioids. As for tramadol, there's not enough evidence. There is lacking data on safety and efficacy in children. So therefore, the recommendation is to avoid in children below 12 years. And when you have children above 12 years, you can use them, but with caution. Opioid overdose, it's something that can occur, and usually it occurs from the miscalculation of the dosage. So we're not the quantity of the dose or the opioid that you're supposed to give, and you're not able to calculate, that can lead to opioid overdosage. Sometimes is exploratory injection. Children tend to ingest things that comes to their reach as they tend to learn. So this is something that they can by mistake ingest, and when opioids. So therefore, careful storage of opioid is very important and should be out of reach of children. And in adolescents, they can abuse drugs for recreational use, which can lead to opioid overdose. So therefore, it's very important even in adolescents, before prescribing opioids, to identify get the history of any drug abuse or any recreational drugs that have been used before. The classic findings on examination in cases of opioid overdose is pupillary constriction, meiosis, where the constricted pupils, central nervous system depression, respiratory depression, and other symptoms that can occur is hyporeflexia, hypothermia, bradycardia, hypotension. Management usually begin with respiratory support, trying to support the respiratory system. You can use the mechanical, invasive, non-invasive, or methods. There has been some literature talking about the use of activated charcoal when you present within 1 hour, but that can only apply when patients are not don't come in respiratory depression. There's just a history of a possible opioid overdose, so they can use activated charcoal. But when they come in with respiratory depression, you want to start supporting their respiratory system and administer the antidote, the naloxone, which can be repeated. The dosage can be repeated every 3 minutes until the improvement in respiratory depression is noted. Caution: children who have been on opioids and has been controlling their pain well, when you administer the antidote naloxone, that reverses the effects of the opioids, which may evoke extreme pain, or you can notice withdrawal reactions. So when you are administering your naloxone, please keep in mind that these are patients who can come with present or they can instigate extreme pain. So therefore, alternative analgesics should be readily available for these patients, and monitor the signs for any withdrawal signs which can be instigated or appear because of using the antidote naloxone. Importantly, about breakthrough pain. So this is a pain that is a transitory exacerbating, which is experienced by the patient who has relatively stable and adequately controlled baseline pain. So patient has been on a regular scheduled dose of analgesia and has reported stable and adequately controlled pain. Then after which sudden develops severe sudden pain, which they experience. So baseline pain and breakthrough pain are different entities and should be addressed individually. It's usually abrupt in onset, severe, greater than moderate intensity, and short-lived. Cause and anatomical site is often, but not always, the same as that of baseline pain. It can appear or can be very non-specific as well. So the management is recommended is to use the immediate release morphine, and IV morphine can also be used. So for management of breakthrough pain, you use what you call the rescue doses, which are calculated as 5 to 10% of the 24-hour opioid dose. And depending on the pain, you can be giving the rescue doses more frequently to manage the pain. If multiple rescue doses are required, the baseline 24-hour morphine dose can be recalculated. So some literature say if you have more than 3 rescue doses, some literature I came across talking about more than 4 episodes of rescue doses. More than 4 doses of rescue, more than 4 rescue doses, or more than 3 rescue doses. You can consider recalculating the baseline morphine dose, adjusting the regular baseline morphine dose. Adjuvant medicines. These are other medications whose primary role is not pain management, but can be co-administered with analgesics to enhance the pain relief. And they are used in specific cases like neuropathic pain, bone pain, muscle spasm. Now, in pediatrics, there is very limited literature about the use of adjuvants in children. So for steroids, from experiences, it has been indicated in CNS tumors, patients presenting with raised intracranial pressures, spinal cord or peripheral nerve compression. But the use in children, there are no studies which support the use in children. Same for biphosphonates, usually for bone metastasis. It has been used in adults, but in children, there are no systematic reviews or RCTs to support the use. Antidepressants are also commonly used in adults, but in children, they're used on based on clinical experiences. Same with anticonvulsants as well, for benzodiazepines and baclofen for muscle spasm and spasticity. There's no good evidence to use in children, but there are experiences of usage in adults. This is something which I found it's something that I'm not sure if we are actually focusing on or we consider this. There is evidence that shows that including the parents psychologically based in pain management interventions actually improves pain outcomes for children and adolescents. There is literature showing that parents who have a child with cancer are not readily gaining access to well-established evidence-based psychological skills training that can help mitigate pain and pain-related stress. Therefore, there is need to generate adaptable, evidence-informed interventions that support and empower parents to help their child with pain management. It's the using of psychologically based management. This also helps in managing the distress of the parents as well as the distress of the child, because there's literature showing that parents who have children who are undergoing cancer, who have admitted in the hospital or who have cancer, having pain. So it also impacts the behaviors of the parents. And if the parents tend to get more anxious or have negative response towards the pain of the children, it again impacts the outcomes of pain management in children. Therefore, involving them and educating them and providing interventions that support and empower them will help in the overall outcome of pain management in children. These are my references. Thank you.
Thank you so much, Dr. Hussein, for the wonderful presentation. We'll now go to the Q&A session. There's a lot of questions about the webinar for yesterday and the recording. Please go to the KNH website, look at research and programs. You'll find the recordings of the webinars there. So to start off the Q&A, there's a question here. Is it possible for a child of 2 months to get exposed to cancer or get affected by cancer?
Thank you. Yeah, I mean, cancer can occur to anybody at any age. So a child of 2 years can also be affected by cancer. I hope that answers your question.
Yes. Now, about opioids, Doc, there's you mentioned that weak opioids are not to be used in children, but does that just apply to cancer, or, for example, children with sickle cell presenting in acute pain, can we still use tramadol and codeine on them?
Thank you. So actually, it applies to all the illnesses and all the children, not specific to cancer as well. They're actually saying that they've seen more fatal cases with the use of codeine compared to tramadol, but the FDA actually put a recommendation against the use of both, in that because of the metabolism rate. So, I mean, I have seen people still use it, but you have to use it with caution, where you know that you can closely monitor this. But actually, the recommendation is to use against them, and it's across all diseases and all children.
So a question on pethidine. Someone asks that pethidine can only be administered in hospital. The appropriate pain management and medicines with less side effects while at home.
I'm not sure if you have any guidelines. I mean, the Kenyan-based guidelines on that, but a lot of like the American and European guidelines actually recommend against usage of codeine and tramadol.
Okay. Now, again, there's no questions about morphine. There's a question about sublingual morphine. As far as I know, the same oral preparation is what we use sublingual. Because someone is asking, do we have sublingual morphine? There's also myths that morphine should not be used in children. Maybe you can tackle those two questions together.
Thank you, but I agree with you that the same oral morphine that we have is the same one that we use sublingual. Actually, you just use the syringe and just push it below the tongue. And about, sorry, the second question was the use of morphine in children.
Yes, that morphine should not be used in children. And mostly is the fear of respiratory distress.
Right. So yes, I know there are fears of use of morphine in children, and that's one of it's actually been considered as one of the barriers to adequate pain management. But having the appropriate dosage and initiating at the low dose or the recommended dose, and then gradually titrating with frequent assessments at interval, actually the risk of developing respiratory depression at that point is minimal. Respiratory depression actually has been seen in only cases where you have overdosage of morphine. Sometimes when you're prescribing your opioid as well, also consider the liver function and the kidney function, because you want to adjust your dose according to the functionality of your kidney and liver. Usually in kidney function, if you have reduced kidney functions or liver function, you begin much lower with your dose. Yeah, I think that's what I would say. I don't know if you want to add anything, Dr. Nafula.
No, not for now. Also, you talked about the morphine preparation being 10 milligrams per ml that you have in Eldoret. In KNH, we have two preparations, the adult and the pediatric. So the pediatric formulation is 1 milligram per 1 ml. So it's very important that for children, you try and prescribe morphine with their weight, and you also look at which formulation is available in the pharmacy. So it is good not to just prescribe mLs. You can write 1 ml, but the preparations vary. There are some that are 10 milligrams per 1 ml, some that are 1 milligram per 1 ml. So it's very important to be sure about the milligrams that you want to prescribe so that it can now be converted to the milliliters so that the child gets the appropriate dose. Now, the final question is about cataflam, NSAIDs. There's widespread use of cataflam as an antipyretic. Please comment on that. And also, we've seen T-sheets where Panadol and Brufen are being used together, yet on the WHO ladder, they are falling in the same class of managing mild pain.
Thank you. So currently, I mean, medicine has moved into more of evidence-based medicine, and from the NSAIDs that are commonly, I mean, that are being used commonly, there's a lot of evidence about preferably, I mean, using of Brufen, actually, which they say in terms of the adverse effect profile, it's safer to use. About cataflam, yes, there are the pediatric preparations, but again, in very younger children, if I'm not wrong, below 6 years, there's no much, I mean, there's no evidence on the use of children below 6 years, but older, yes, I've seen it being prescribed and they are using it. So I don't have personally much experience with the cataflam myself, because I've seen with children with mild pain, usually Brufen and paracetamol actually works pretty fine. Yeah. I don't know if anybody has experience on the use of cataflam, can share probably.
If anyone has experience, you can type in the chat or raise your hand. Now, Doc, what about the practice of combining paracetamol and Brufen? Because it's quite common to see a child having a prescription of both paracetamol and Brufen.
Yeah, I mean, I agree, but you can actually, for mild pain, you can use either alone paracetamol or Brufen, or you can also use in combination. But that depends on the response to your, if you're giving it for an analgesic effect, and you prescribe your paracetamol, and if you don't get the adequate analgesic effect, then you can combine it with together with Brufen. Yeah, but for the beginning, I would say you start after your assessment, you can begin with just one analgesic, and if you have inadequate, then you can combine. And then from there, if you still have inadequate analgesic effect, then you can go climb the ladder and go higher.
All right, thank you so much, Dr. Hussein, for sparing your time to talk to us about managing cancer pain in children. We look forward to hosting you in future for other presentations. Thank you to the attendees for sparing time to join us. We'll be inviting you for more CMEs in future on aspects of pain management. Now, the other questions in our chat are about, there's one concern about increasing the number. Now, I think the maximum number of attendance for Zoom meetings is 1,000. So try and log in early so that you're among the 1,000. And in case you miss a webinar, you can check on the website. It has been projected here, where you'll find the recordings of previous webinars. And CPD points are usually sent to your email. In case you haven't found them, you can contact our research department via email. Wait, let me tell you the correct email. Nelson, can you project the email? Yes, knhcpd@gmail.com. You can send your inquiries there. So thank you for your time. We would like to end the webinar there for today. Until next time.